Hi everyone, good evening. My name is Elise Kramer and I am Public Education Chair for the Scleral Lens Education Society. And I'm super excited to introduce two of my amazing Canadian colleagues tonight who will be talking about scleral lenses for dry eye. So Dr. Morrison, Dr. Sheila Morrison studied at Pacific University College of Optometry, where she earned her Doctor of Optometry, Master of Vision Science and residency in cornea and contact lenses. She has served on faculty at the University of Houston College of Optometry and currently practices at Mission Eye Care Center for Dry Eye and Corneal Disease in Calgary, where she is also a clinical instructor for fourth-year optometry students on rotation from the University of Waterloo. She enjoys lecturing throughout North America about topics related to ocular surface mapping, myopia management, and specialty contact lenses. Dr. Morrison is a fellow and extended board member of the Scleral Lens Education Society, editorial reviewer for the Journal of Contact Lens Research and Science, and a board member of the Cornea and Contact Lens section of the Canadian Association of Optometry. Dr. Andrea Lasby has a Bachelor of Science from the University of Calgary from 2009 and graduated with a Doctor of Optometry at the University of Waterloo in 2013. She completed a cornea and contact lens residency at Northeastern State University, Oklahoma College of Optometry in 2014. Dr. Lasby currently practices in Calgary as a partner at Mission Eye Care. She's a fellow of the American Academy of Optometry and the Scleral Lens Society. She currently serves as president-elect of Alberta Association of Optometrists. It's a huge honor to have you guys tonight. Thank you so much for volunteering your time and looking really forward to your presentation. All set, guys.
Awesome. Thanks so much. I think that's a mouthful that you had to go through there, so thank you for that. It is a pleasure for us to be here right now. Thank you for joining us. We're here to talk about one of our passions, which is scleral contact lenses, in particular scleral contact lenses for ocular surface disease patients. So a little bit about us. We do have some financial disclosures to go over, and yeah, Dr. Morrison and I work together. So we are work-wise here in Calgary in Alberta. So we are going to try to keep this as interactive as possible. You guys have been going through a year and a half of virtual lessons and lectures right now. So we're going to use PolEV, and if you haven't used it before, then I'd recommend going to your polev.com/AndreaLasby141 on your phone, or you can do it even on your computer if you want to, go to a different screen, your call. And it's going to allow you to chat with us and kind of be a little bit more, we'll know who's out there and we'll see kind of what you guys are saying. So for the first thing that we're going to do in order to keep this fresh, if you're on that PolEV, we'll give you guys a minute to log on. You can click on this picture, show us where you're logging in from. Where are you joining us in, from? I know we have some coming from the East Coast to the West Coast. Do we have any overseas? Let's see where things are. So we'll give you guys a minute to log into that.
Look, we're getting some answers. Exciting.
I put mine in there. It looks like I'm in Saskatchewan, but we're actually in Calgary. Nice work. You guys are figuring it out. Good job. Cool. So again, if you guys forget those instructions, every time we have a poll pop up, the instructions are going to be on there that you can just go to polev.com and you'll be able to join us. Oh, we do have overseas, maybe.
Amazing.
That's exciting. Thanks for joining us, probably in like the middle of the night. So thanks for that. Cool. Awesome. Great job, guys. So Canada, USA, repping it well for North America. Great job. So what is the deal with dry eye and sclerals? Scleral lenses, we're going to talk about some indications for scleral lenses and how they help. We're going to talk about neurotrophic versus neuropathic pain, and we're going to be talking about some fitting considerations. A lot of you probably already fit scleral lenses. So what are the specific things we think about when we're looking at just dry eye patients? And then finally, we're going to end with some mental health considerations, which is really crucial during COVID, and something many of you probably have run into a little bit. So we want to spend some time on that topic specifically. So talking about dry eye, you guys have probably treated dry eye with many of the options that you see up here. We always recommend that scleral lenses be just another tool in your tool belt when you are treating dry eye. So, you still want to go through for these ocular surface disease patients. I would never just start with the scleral lens off the bat. See what's causing their dry eye. Is it aqueous deficient? Is it evaporative? And if so, is there something we can do to treat the cause? So if it's a gland issue, if there's obstructions, what can we do to actually improve that? Let's treat the lids. Let's clean up the lids. Let's do all of that first. Then when you have dry eye that is not responding to treatment, then it's really important that we say, okay, you know what? We've got this ace in the hole. We've got this, secret tool up our sleeves that we can use for patients that are just not responsive to treatment. Or even you've probably had those patients that their signs start to improve, everything's looking good on their end, but then the patient comes back and their symptom score is just still through the roof. They're just still in so much pain. And even with all of the treatment you've done, it's not any better. And that's what scleral lenses can be really good for. So, of course, we want scleral lenses to be part of your larger treatment protocol, but reserve them generally for last resort unless that patient has several indications for scleral lenses. For example, let's say they also have keratoconus. Okay, well, definitely scleral lenses would be a great option because they already need it to correct their vision. So there's a whole variety of other indications that would point to scleral lenses. So if there are others, then definitely you might kind of come into your treatment path earlier. Now, as far as maintenance therapies, I just had a new patient referred to us today for ocular surface disease for scleral lenses. And it was really, it's a very important part of my treatment discussion with him to say, hey, I need you to keep doing what you're doing. I need you to keep doing all of your lid therapies. I want you to keep doing your lid hygiene, your warm compress, lid massage, everything, your hypochlorous spray. Keep going with all of that because it is not only going to continue to improve your symptoms, but it's also going to make sure that the lenses don't fog. And we're going to get into that as well. So, Dr. Morrison is going to talk about that a little bit later when we talk about wetting problems that we run into. So what are your goals? Why, what are we going to do? What do we hope to see with the scleral lens when we fit it for dry eye? One, we want to reduce comfort, improve comfort or reduce pain. Two, we want to improve vision. You can think of that patient that has SPK all over their cornea and their vision is crummy because they're just seeing through this really, really terrible tear film. So certainly scleral lenses can improve vision. We want to resolve keratopathy. So anything that's non-resolving, so patients who have these epithelial defects, even with steroids, bandaged contact lenses, they're just not resolving. Scleral lenses are great for that. And then finally, we want to protect the ocular surface from further damage. So if these patients have really keratinized eyelids, if they've got scarring, we don't want them to blink over those injuries over and over and over again. So again, that really sensitive, corneal tissue, that lens is supposed to now protect it from further wear. So how do scleral lenses do that? How do they improve things? How do they make it better? So first, the lenses do provide a fluid cushion over the cornea. That's obvious. I imagine everyone that's fit a lens understands that. But they do provide the cornea a chance to finally heal. So if it is not being rubbed constantly and that inflammation is not, that vicious cycle is not going over and over and over again, then those production of those inflammatory mediators will reduce over time. Of course, again, we talked about it's going to protect against things like trichitis or keratinized lids. And then, of course, it's going to improve the tear lens, tear stability, and other irregularities arising from any corneal scarring. So again, scleral lenses are great in that they don't touch the cornea. They're perfect for treating ocular surface disease. So what does the literature say? Does it work? How does it work in practice? So we know from a whole bunch of studies that dry patients that are really, they don't show any improvement from previous dry eye therapies. 85% of those patients fit with a scleral lens reported that they had all day long comfort, and 75% of those patients reported that they didn't have to use their artificial tears as frequently. This is really important. Case in point, my patient today, the only reason why he wanted it to come in is he's like, I take my artificial tears like every 20 minutes. What can I do so I don't have to put these in constantly throughout the day? And scleral lenses certainly can do that. And of course, both those things improve quality of life, which is the whole point, considering your patient as a whole person. We also want to look at they looked at a review of 50 studies and that found that scleral lenses are well tolerated for use in dry eye syndrome and improves both their symptoms and visual acuity while having only very few complications. And what's really important about this review is it looked at 18 manufacturers and 27 specific lens designs, including a whole range of diameters from anywhere from 12.5 all the way up to 22 millimeters. So I think what's been kind of lost in the literature at times is you'll get one paper here, and it's really focused on one lens. So you can only prove that lens helps ocular surface disease, but what about the next one? And a lot of, those who are pros practitioners out there, if you fit pros lenses or not, they're excellent, but there's a lot that are done just on pros. And so a lot of, especially in our community, the ophthalmologists were like, well, there's no papers on any of the other lenses. Well, that's not true. So there are lots of papers out there on a variety of manufacturers. So it's not just pros lenses that can help. It's really any scleral lens. The theory is the same. Short-term scleral lens wear, so 8 hours, improves symptomatology and signs of dry eye, including osmolarity, which is really interesting. And also they found, which was really interesting in this study, they found that the MMP9 actually increased, but they theorize that's happening because of tear film stagnation and use in that study of preserved saline. So that was a big problem with the study and a big limitation, because we know for any dry eye patient, especially, to be honest, any scleral lens patient, we don't want them using any preserved salines under the lens. Now, with the use of commercially available scleral lenses, your improved comfort, ocular surface protection, resolution of keratopathy, this was all achieved in all but 2 cases. So there's 115 cases that the Shornick study looked at in 2014, and all but 2 showed that there was improvement, which is amazing. So again, this is really showing that try it. If patients are running, and if you're running and hitting your head against the wall because nothing's improving dryness, try sclerals. They're definitely going to be a very helpful tool for many of your patients. What's really interesting about the last study, subjects had already attempted it on average 3.2 other forms of intervention. So that's really important to know, that your patients are going to probably try a whole bunch of other things before they land up in your chair. So be patient with them, because they have probably been through the ringer when it comes to seeing a lot of their different practitioners and other doctors. So we're going to move into scleral lens indications. You guys are smart. You probably fit many types of scleral lenses. So instead of me just telling you all of the indications, I want you guys to tell me, what do you think some indications could be for scleral lenses? And you can just put in one word if you want. And I'm going to put in one that I think is like super common, keratoconus. Anyone else? Oh, I spelled it wrong. Good job, keratoconus. Someone else spelled it right. Good job.
And if you agree, if that's your thing, put it in.
Yeah,
anyway.
Put it in, because then we're going to get it to go. It'll go bigger and bigger. Lots of people think keratoconus. Awesome. What about? Yeah. Oh, you guys, good job. Graft versus host disease.
Save this.
Oh, I'll take a picture of it. Yeah, I'll take a screenshot of it. Yeah, great job, guys. This is awesome. Look at that, ectasia. Yeah, transplants, great grafts, sports pain, neuropathic pain. Well done. Yeah, of course. We knew we were going to have a smart group on here, and you guys are like proving us correct.
This is phenomenal.
That's awesome. I don't need to teach you guys anything, but I'm going to take a picture of your amazing answers. So great job. That's super cool. Awesome. So let's talk about indications then. You guys nailed it. Like, I mean, I put 5 down, and you guys had so many.
So awesome.
Yeah, good job. You guys did great. So you're right. The studies show that about 75% roughly of sclerals are going to be prescribed for different types of corneal irregularities. Another 10% for just honestly high refractive error. It could be high myopia, stigmatism. But interestingly, and most importantly, 16% are going to be prescribed for ocular surface disease. So really important, because I think that this part of scleral lens fitting is expanding rapidly. It's super crucial. I mean, in our part of Canada, it's like a polar desert up here. It's super dry. Most of the year it's kind of cold. So it is definitely necessary in areas like ours, which are honestly really, really dry most of the year. So when we talk about ocular surface disease indications, there's lots of them. Could be dry eye, Stevens-Johnson syndrome, which is what you see the picture of here. Graft versus host disease, we see a lot of Sjogren's, just recurrent corneal erosions. If you have one of those patients that just, honestly, you've tried everything, maybe even surgery, and those RCEs just keep coming back. Neurotrophic keratitis, as you guys said, but also different types of exposure keratopathy, like Bell's palsy, for example, is also a good one. And there's lots of studies out there. Again, I'm not going to go through them all, but just to kind of put up a few of them here, lots of them showing that the improvement we see with scleral lenses for dry eye syndrome, it is a valid and really important treatment to be offering for your patients. So we know from DEWS 2, dry eye is multifactorial. There's a sliding scale from evaporative all the way to aqueous deficient, but there's also that component of neuropathic versus neurotrophics. And that's how we all see it. Sometimes signs don't match up with symptoms. Sometimes we see patients that should be in 9 out of 10 pain and they like don't feel a thing, right? And then we have other patients that feel that they are in so much pain and we look at their eye and it looks amazing. There's no staining, it's white and quiet. How are they in so much pain? So I wanted to talk about that, but I wanted to hand it over to Dr. Morrison just to talk about this case really quickly to get us started.
This is a cool case actually that we had actually at our clinic right when I came back a year or two ago. And this gentleman was referred over from his ophthalmologist. Main reason was because he's had a PKP, needed specialty lenses from our office, and he actually presented. I'm not sure how his other doctors really, were comfortable with having his lid as swollen as it was, but what had happened is you can see in the picture here that there is a pretty serious inflammatory reaction going on underneath his upper eyelid. And when we investigated a little further, it turned out this patient had, in healing, he had a suture that was a little bit loose and a regular kind of rough corneal surface that had essentially created horrible GPC and inflammation. And so for him, we use scleral lenses in this form of, ocular surface disease includes lid disease and lid injury. It's all part of what we use scleral lenses for. So not only do we protect the cornea, in this case, we use the lens to protect the cornea from its own eyelid. And it was a wonderful result for this patient. Now, this translated into kind of another complication though, because once we calmed down the eyelid with the scleral lens, it turned out we ended up having to deal with a neurotrophic cornea because he was very, very prone to not feeling something if something was wrong. And this is something that we come across with our ocular disease patients frequently, I would say, where we have, a lens that, could potentially be creating epithelial defect that they won't feel until it's really, really bad. This patient, again, from his suture line, ended up with an infection that he didn't really realize was happening until it turned into a full-on ulcer. So this was a really interesting case that showed, again, lots of things can kind of happen when it comes to the ocular surface. And in this case, the scleral lens ended up being a great protection for the eyelid, but then we had to think a little bit more about the neurotrophic cornea, and which Andrea will get into a little bit more.
Yeah. And so when we talk about neurotrophic keratitis, it can be sight threatening, there we go. And so it is a degenerative corneal disease, and basically the trigeminal corneal nerve has decreased sensitivity. You all remember from optometry school, using a Q-tip and just saying, hey, you have any sensitivity here? Sometimes it can be caused by, and herpes can certainly bring that on, but sometimes there's no cause. Like patients just show up and they're like, I don't know what happened. I just woke up one day and now my eye's blurry, and that's all they know. But you're looking at it and the cornea is just pretty much trash. So this really leads to epithelial breakdown, compromised healing, and development, as Dr. Morrison said, of those corneal ulcers that can happen, and potentially perforation if it's not caught in time. So neurotrophic keratitis requires really diligent, conservative care, and you really need to monitor for corneal conditions with these patients. And again, that scleral lens is great to protect the cornea from that external environment and prevent and promote healing. So even if the patient's not feeling pain, we still want to heal that cornea. And at the same time, it will provide better visual acuity through the neutralized optic zone as well. Now, for those of you that have tried Oxervate in the States, I'd love to hear your feedback on that one. It's not a drug that I have tried, so I'd be interested to see kind of what you guys think. But certainly for us in our practice here in Canada, we use scleral lenses a lot for this. This is just a quick example, actually, that Dr. Morrison had of a patient with diabetes and also presumed previous herpes simplex infection as well. And you can see how terrible that epithelial defect is on the left-hand side. After wearing a scleral lens, you can see that how much of an improvement we see in pretty much just about in less than a week. So for something that is just non-healing, these big open wounds, yeah, the scleral lenses can be so helpful for these cases. Now, what about extended wear though? So what if you have a patient, let's say with a Bell's palsy or something, they're not closing their eye at night and they have these huge epithelial defects, then what? And there's been a lot of studies done kind of looking at using lenses, certainly overnight. This one was really interesting. It was done by Dr. Perry Rosenthal, and it found that about 5 out of 7 epithelial defects associated with Stevens-Johnson syndrome had healed after having like extended scleral lens wear. And 4 of these happened within 7 days. So doesn't necessarily be something you need to prescribe your patient for. Like certainly you could put a lens on if it's fitting well from your trial kit. There's really no rules saying that you can't just dispense that for a week and see if it heals. And within, for 3 out of 7 non-Stevens-Johnson syndrome epithelial defects, those reepithelialized within really 36 hours, which is really cool. Now, which is really something you do have to think about. And the only reason why I've never done this before is because of the risk of MK. And in this study, there was a significant risk of that because it occurred in 4 out of 14 of the eyes that they did this for, and led to a graft failure in 1 eye and required a repeat graft. So it's not without its risk for sure. You can certainly do it, but if you are going to do kind of full-time extended wear to help treat this, I do recommend probably daily follow-up. You really just need to be on these patients, make sure it's getting better, and do it pretty much, I would say, for a short period of time, and then kind of encourage them at nighttime if you can to lid taper or have goggles or something like that. Now, switching over from the patients that don't feel anything to the patients that have neuropathic pain, these can be certainly our most challenging patients. These are the patients that are going to come in with dark sunglasses, you know, and honestly being led by a family member because they can't even open their eyes. Like they haven't even looked at their family members for a year. They're essentially blind because opening their eyes hurts so much. And you examine these patients and they look great. You know, it's really, these ones are super, super tricky. And many of these patients, even when we put in a drop of Alkane to just numb them, they report having, you know, incomplete suppression, there it is, of their eye symptoms during total topical corneal anesthesia. So spontaneous pain is something that certainly you cannot fix with a scleral lens. So if you put in a drop of Alkane and the pain does not completely go away, a scleral lens really isn't going to work too much, and many of these patients will have to resort to something like gabapentin instead. So certainly if you put that contact lens on, and these are my favorite patients, you put the contact lens on and immediately they're like, oh my gosh, this is great. You know for sure instantaneously that that is going to help that patient and you can kind of continue on. But if you have someone with this level of pain and you put a lens on and they're like, I don't feel anything different, it's still super painful, or even you put that drop of Alkane in and doesn't completely numb their pain, it's not going to be a great option for them. And sometimes you just need to know to be able to tell patients, listen, you know, this works for a majority of patients, but in your case, you know, it's not quite numbing the pain like we had hoped. Now, the tricky thing is, and what Dr. Rosenthal again did some research on, is that after sometimes months or years of very successful scleral lens wear, all of a sudden a patient may become intolerant, and I can't explain why. It's happened to me for a few patients where they've been wearing the lens for years and years, and all of a sudden they're like, now it's painful and there's no change in the fit, everything looks good, their corneas look great, so do certainly watch out for that. It leads me into this case study that I want to kind of get through in the next couple minutes before I hand it over to Dr. Morrison again. So this was a 32-year-old Asian post-LASIK female patient who presented for a scleral lens fit for a dry eye. Again, her symptoms are worse in the winter, worse outside in the wind, and when working on the computer. That's when our blink rate drops, right? So she had previously tried pretty much everything. She, you know, had come from an ophthalmologist. She's like, I went to an optometrist, I went to an ophthalmologist, I did all these things, and I'm still, you know, having problems. And when I take a look at her, her signs weren't that bad. You know, a little bit of redness here or there, really no staining, but certainly her symptoms were still quite high. My biography, yes, she did have some recession there, but her tear breakup was not bad. You know, 8 seconds, it's not terrible. But when we did Alkane, it did improve her symptoms immediately. So we did proceed with sclerals. But then how do you know which size of scleral to choose? How do you know which one to go with? What's going to be the best option for your patient? So that drives us into lens diameter. So usually in the past and with fitting sets, usually your HVID or horizontal visible iris diameter drives your lens selection. So there is a group of people out there who, you know, in the research has shown that you want to start small because you don't have a super asymmetric sclera, the closer to the cornea. You can also get closer to the eye. You can go with a thinner lens. You're going to promote oxygenation. And so that's certainly one camp. And then there's another camp which talk about, you know, larger lenses are certainly necessary, especially in cases with ocular surface disease when protection is warranted and you want to widen that distribution of weight on the sclera. And you want to be kind of like that wedge heel, right? We don't want to kind of come down like a stiletto. We're putting all the weight on our tiptoes. We want to kind of land in a wider area, which is why I think for a lot of ocular disease patients, especially those with a pain component to their symptoms, it's better to kind of go with a larger lens and protect a larger area. So back to our patient, we did decide to go with a 19.0 millimeter Boston sight lens. And again, it's just to try to cover as much of the sclera as possible. You can see how red it is outside of the lens edge. There's not like true blanching or impingement here. It's just that's kind of the, you know, normal appearance of her sclera when it's not underneath the contact lens. And immediately when we put it on during the fitting process, she was like, oh, this feels amazing. You know, this, I have no problems. It was just like if you put a drop of Alkane in my eyes, it feels great. And these are the ones where you're like, swish cash, you know, like let's go all in with our poker chips here. These are the ones that you hope to, because you can certainly change their lives. And this patient has now been happily wearing this lens for over 12 months of full-time wear. And you can really see from these pictures how big this lens is. Look how far it's going on the limbus, like it's quite large. So do know that, you know, there is a little bit of we have a caveat to that. Sometimes you can't go that big. You do want to go as big as possible, but in cases like this one with Stephen, we had a Stephen Johnson patient come in. When you have someone who has really small palpebral apertures, or you have someone with symblepharon, sometimes you can't go as big as you want. So in this case, for example, this patient had excellent symptomatic relief with just a small lens. I believe this one was like about a 15.2, and she had great success. So certainly, you know, that's something to consider, because there are limitations to going larger, and sometimes you do have to co-manage with their ophthalmologist if they do have some blepharons that need to be kind of resected back. But that brings us to, you know, we know how small is too small. Obviously, we don't want to touch the cornea, but how big is too big? You know, if you're a big dog lover like I am, the answer to that is like the limit does not exist. But at some point, you're going to start interacting with the muscles of the eye. If you go big enough, you're going to run into the insertion and where they kind of insert into the eye itself. So what muscle would be first impacted by fitting too large of a scleral lens? What was going to limit you from going endlessly large and wrapping around the whole side of the eye? What do you guys think? We've got, looks like some people saying, most people saying medial rectus, some saying the obliques for sure. We'll leave it on here for just a little bit longer. I mean, overall, you guys, again, super smart group. We don't need to teach you anything. You're right, it is the medial rectus. So if you keep going larger and larger, the muscle that inserts closest to the limbus is the medial rectus. You only have 5.5 millimeters between the cornea and the limbus and where that muscle does insert in. So no, and that's part, you guys know, that's the reason why lenses will tend to incenter or decenter inferior and out temporally, and that can also create vision disturbances as well, because that's the highest raised part of the sclera. Dr. Morrison will tell you, because she's a scleral shape expert, that is what we see from, if you're going to do eaglet, if you're going to do SMAP, you're going to see those, always the medial edge is going to be the highest. But when we go really big, you don't want to impinge that muscle, so there has to be a limit to how large you can go. What's the largest lens you ever fit on a patient's eye?
Probably about 20 millimeters is probably the biggest for me.
Yeah, I agree.
I'm not any larger in the practice right now that you know?
No, we only do 20. 20 is the largest we have. 19 I use more regularly. 20 I've done a couple, but I find that they can be really tricky because the toricity out there is massive. Yeah. But I think a lot of our patients are generally happy in a 17 to 18, to be honest. We just don't, I don't go with like a mini scleral, like something less than 16. I usually avoid those ones.
Not for ocular surface patients.
Yeah.
Mm-hmm. Well, you know, thanks, Andrea, so much. That moves us into our fitting considerations. And so, you know, just like any other indication, we need to look at our ocular disease patients, or, you know, dry eye, trauma from their ocular disease. Look at these people as a whole and consider their ocular shape. And when we make decisions about fitting style, including lens diameter, what are we going to use in the lens reservoir? It sometimes can be a little bit different for our patients with ocular surface disease that we're managing. And we're also going to talk a little bit more about, you know, fogging versus surface wetting and those types of things as well. So as a review, just to bring us back to Andrea's beginning here, being our goals for scleral lenses when we use them for our OSD patients. So number one, of course, improvement of comfort, reduction of pain. Vision has to be there too. You know, sometimes we'll run into patients, I don't know if you have this in the clinic, I have one going right now that's in tomorrow again. You know, your Plano patient with horrible ocular surface disease who doesn't normally need glasses anyways is probably one of my toughest fits. And so paying attention to the right optic, one that's complementary with the right kind of optical design, and being very mindful in these patients, you know, not to overpromise a multifocal. You'd think that the normal cornea can handle it, and a lot of them can, but you know, the optic can be really tricky in these patients, even when you think the optic should be a home run. And then of course, protection is the big one. So when we fit our dry eye patients in the clinic, we still go down the same path as we do for any other patient. And we do consider, you know, do we fit empirically? Do we use a diagnostic lens fitting set? And at Mission, and I'm sure a lot of you out there do have access to both, you know, a scan system or taking impressions, which we'll talk about a little bit, versus our more traditional diagnostic lens fitting. And, you know, of any of the different indications for scleral lenses, I would say that our diagnostic lenses are so important for this population. And the reason for that is because we really want to give them the experience. A lot of times patients with really bad dry eye that have tried other therapies are going to come in with, you know, frustrations, and they've had failures, a lot of them, and have really little hope in some cases. Sometimes, as Andrea was talking about, you know, we want to test to see the viability of this device. Is it going to solve your pain? But also to kind of quell their nerves, show them how nice and comfortable that the scleral lens can be on really dry eyes compared to maybe their corneal GP dropouts, soft lens dropouts, and other kind of concerns that they have. And that can be a point where we really gain trust in the clinic. This patient that you see, it was the one that was in about a week or two ago with very severe ectopic keratoconjunctivitis, conjunctivitis, really bad scarring on the right eye. Left eye cornea is pretty clear, but his ocular surface was just trash. And in this case, the diagnostic fit was absolutely necessary. Number one, so that I could assess his visual acuity potential in the right eye to see if it's even worth fitting a lens on both eyes. And then number two, just to, you know, show him the feeling. We fit both eyes because the vision gain was not great in the right eye, but the epithelial defects were horrible in both. So we're just in progress with this patient now. And the diagnostic fit was really important for us in that fit. So we fit using trial lenses, and we fit utilizing a sodium fluorescein deduction system. So what this means is when we place a lens on a patient from a trial kit, we can actually deduce the shape of the lens that we may desire based on our fitting style by looking at the relationship between the contact lens and the cornea. And you can see that, that with the fluorescein pattern, because the fluorescein will pool where the lens is further away. Measurement tools also today include digital scanning and impression molds, which are all utilized in our practice. And I would say, you know, each tool has a place. Scanned or imprinted lenses often can be very helpful when we're dealing with patients who have other comorbidities. You know, every eye is its own unique fingerprint. And so we cannot just look at the ocular surface when we are evaluating a patient for candidacy and for selecting lens size, shape, you know, what fitting modality we want to use. We need to look at that fingerprint as a whole hand. So in this case, we go beyond the cornea. And in some cases, when we do have our dry eye patients, often I'll get one that has had some other injury or has a, you know, extremely asymmetrical sclera, in particular those dry eye patients that are referred from out of town. Sometimes it can be a little quicker to optimize that fit first a little earlier utilizing the digital scanning, and patients love the technology, so we do use that a lot in our practice for our dry eye patients. Now, when it comes to our reasons to continue using trial lenses, we wanted to really include this summary slide to hit home the main reasons that we will not be letting go of diagnostic lenses. We actually utilize digital scanning of some form, whether it's an impression mold that turns into a digital scan or a profilometry, corneal topography extrapolated. There are ways that we evaluate every single patient in the clinic. Now, some of our dry eye patients with the technology that's available, if your ocular surface is really, really trashed, it can be hard to get great quality data. So that's one reason we're going to put a diagnostic lens on to confirm our findings, including what is the predicted sagittal height of a lens we're going to order. But more importantly, testing acuity potential through corneas that are scarred and have a lot of defects, although a lot of those patients improve their vision. Once we can kind of heal it over and get a smooth surface that stays on for a while, patients actually can improve their vision. Demonstrating comfort, testing for relief of pain symptoms. Andrea is really, really good in our office at knowing when to call it and knowing when to move forward. And one of the very first things that you need to test is the viability of this device to actually help with the patient's chief complaint. So Altkin can be very helpful. Then of course lens power is always very, it's necessary in most cases to put a hard lens on the eye to get that power. We talked a lot about diameter, but one thing that I just want to talk about just in brief, which we'll get into in our case report that's toward the end, it's looking at the patient as a whole. So we're looking at the, iris diameter, not just in the horizontal anymore, but also in the vertical, because there are differences and that can impact our ability, by failing to look at differences in the horizontal, vertical, even oblique iris diameters, we can actually mismatch a lens or misfit, creating complications for patients that are prone to things like fogging, for example. Lens reservoir in our dry eye patients, typically we always use preservative-free solutions as we went over. We'll go through a list here in a couple more slides. What do you do with fogging and what are some of the main things we do? But the scleral lens reservoir is a really incredible tool in that I think in the future, we will certainly see more and more research coming out looking at that reservoir as a delivery device for medications. So we're using it for autologous serum. PRP drops are a little trickier. I personally don't really use them in sclerals because of the color, but you can. Yep. But the autologous serum we use quite often. And then, in the lens reservoir, there are many, many options, buffered solutions, non-buffered solutions, different pH levels today as well. Now, one of the most important or maybe most common things and complications that I encounter, and I think Dr. Lasby and I have talked a lot about this topic over time. And, the foggy patients are very common when we're managing ocular surface disease, dry eye patients. There's often going to be some amount of management when it comes to the lens surface, or true fogging, which is when we end up with particles that will collect underneath the lens. Fogging sometimes is referred to as, the debris from the external eye that gets underneath the lens. Fogging can also be metabolic products from the eye itself that create kind of a foggy white blur. And, it's really important in the chair to be able to differentiate the difference between true fogging, which would be post-lens reservoir fog, versus non-wetting, which could be the front surface of the lens predominantly, and then depositing. So deposits are very, very common in scleral lens patients for in our ocular disease dry eye clinic. Now, when it comes to the front surface or non-wetting deposits, there are things that we do to mediate this. You can try different solutions for these patients. Treat the dry eye. That's really the underlying etiology in a lot of these cases of having really junky tear film. So that can certainly improve things, including lid therapy to keep the, the lashes nice and clear. Coatings such as Hydropeg are helpful for creating a nice smooth surface to prevent deposition. Conditioning prior to application, I find a little bit more effort on regularly treating these lenses with enzyme cleaners or things like Progent, maybe rubbing your lens with the Clear Care, making sure you're doing that every single day before you, put it through the peroxide solution before you put it through your cleaning. Actually, I think the case that we're about to just quickly discuss, Andrea, you had a patient recently that we ended up with some really hardcore squeegeeing, I think, recently in the clinic.
Yeah, so the pictures that you see here are of a young patient. She's in her 20s and she had an acoustic neuroma removed. And when that happened, it took away her ability to blink fully. So her blink comes down to pretty much where you see those deposits, pretty much like almost like maybe a third of the way to half of the way down. Otherwise, she is not closing her eye at any point in the day. And so you can see how heavy those deposits are, both in kind of like that blue light, but also just you can see them with the naked eye as well. And so we got this tip from Dr. Lynette Johns, where we'd actually take the inserter and we just go on a diagonal angle with the eye open. So you don't have to take it off, clean it, put it back in, because that's hard for patients. They could be somewhere where they can't do that. All they have to do is keep it on the eye and they just put a tip of like just conditioner on the lens and they literally just squeegee it off like you're gonna squeegee your windshield on your car. So it gives them just a few more hours of clear vision before they clean it at the end of the day.
I think I threw a video in of it actually.
Really?
Advance it, I did. Oh, let's see, is it in there? That's okay. We'll get to it if we get to it. So as far as the Squeegee Technique, a great tool that we certainly use. Actually, Pat Caroline and the folks at Pacific use that tool too. So it's something that definitely you want to bring into your practice and teach your scleral patients how to do it to prevent that frustration of feeling like they have to pull that lens off. Now, midday fog, that true reservoir fog typically will happen after some amount of time of wear. So patient, you can see in the OCT number 1, lens is on, nice and clear solution, nothing's really happening there. And in this case, the patient, after 4 hours of wear, can actually visibly, in a slit lamp exam, also with the patient's symptoms, maybe decreased vision, reporting that there's a blur or fogginess after they wear the lenses for a couple hours. You can actually see these more dense particles in the OCT after some amount of wear. Now, there are ways that we mitigate this. Now, in this case, here's a patient with midday fog that is visible on the OCT, and we're able to actually improve the midday fogging just by landing changes. And we're going to go over that next. So you can see that in this patient of Dr. Lasby's, the sagittal height hasn't really changed. It's a settled lens, looks about the same, and the difference is actually just in the landing. And so that's one way that by optimizing the fit in terms of the right amount of height over top of the cornea, uniform height, and we'll talk about that in this next slide. So there's lots of ways that we address midday fog. Midday fog, first and foremost, I usually blame the fit first and just kind of see what's going on there. Midday fog can, again, as I mentioned before, appear as debris that comes from outside if you have a lens fit that's a little too loose in a quadrant or something like that, where there's a little too much exchange. Patients like this, or ocular surface disease patients, tend to have a higher level of inflammation on the eye initially when the lens goes on anyways, so their tears are just full of stuff and it can get underneath it. We want tear exchange, but we want to not have too much debris getting underneath. Now, other things to decrease midday fog tips: decrease sagittal height to the minimum that's safe, decrease the limbal clearance to the minimal that's safe. We don't want to cut off the limbal clearance. We want to clear the limbus, and then appropriately align your lens. So, all of us out there have a slightly different fitting philosophy, but generally we're both the same. We don't want a glove fit necessarily. We want some tear exchange, but we certainly want to have appropriate lens alignment that's going to encourage the most uniform-ish landing all the way around that lens, so that there's no areas of heavy bearing and less bearing. Solution, so we can get preservative-free saline all over the planet. Countries really vary in what's available, as I learned moving back to Canada from the US, where there's a lot more options for filling solutions. But it's really amazing what our industry has done today with filling solutions with varying pH levels. There's buffered versus non-buffered, all kinds of different options. And I certainly, if I get a patient who's a fogger, adjust their fit, I will change their solution to something to see. And sometimes it can be a bit of a trial and error. Using a more viscous drop in the reservoir is very well something that is commonly done, tends to work really, really well. And we'll talk about that in a case down in a couple slides here. One thing I always do also with foggers is really investigate their dry eye status and including allergies. So I'll often put patients on a mast stabilizer or something like that at nighttime, and that can help as well. Some patients just have to take their lens off and refill it, and it kind of sucks. It's not convenient, but it is what it is. And in some cases, I do have patients that switch them at noon. So here's a Pull EV, and this is a patient of Dr. Lasby's from last week. And we have our 4 quadrants. And the question for you is, which quadrant would external debris most likely find its way beneath this lens? If you were to look in your slit lamp at these edges and just kind of see, what would you guess that we would most likely get debris coming from behind the lens? And we'll move forward because and actually really interesting because
this is good. People are super smart.
People are way too smart. So
yeah,
what you're seeing, it's kind of tough to see, but certainly inferior, there's a shadow. And so we're getting some, tear flow there. What about the top portion? Because I actually agree. What's going on there?
Yeah, most commonly in our practice, we're going to see debris coming from the top side. I would say I have no exact answer on this, but maybe like 85% of the time.
Especially on the first lens. And I think this was your first lens for this patient, wasn't it?
It was a fit, actually.
Yeah. And so what happens in this case, even if we have, when the lens is very well aligned, if we're decentering a bit without quite having it perfect yet for our HVID, VVID, the right limbal clearance, we're going to end up with a lens that does gap a little at the top when the eye moves into primary gaze and blinks. It just depends. And absolutely, in this patient, it did come from both spots, but more predominantly inferior.
Yeah.
You're seeing a big shadow on that inferior portion, and that's great. So now another part of this study, I see there's an answer on that kind of area of impingement, and that plays a role too. It's a contributing factor because anytime that we have unequal bearing, a spot that's really too high for that lens, so it's pushing down, it's going to flip the other parts of the lens up. That the lens wants to land, it's a physical structure, it's going to go to the place that's closest to it. And so if it gets blocked by that tight edge, the others that normally maybe would settle in a little better and not be flapping in the wind the way that they are, you know, they're really impacted. And so those edges all play a role on why. And then of course in the vertical is where we see it flowing in a little bit.
And the important part when you're evaluating these lenses is not just to look at it with white light straight ahead, which is important. You're going to see impingement, you're going to see blanching that way, but do take your slit lamp and turn it the opposite direction. So if you're looking at the nasal quadrant, make sure that that light is coming from the temporal side. That's how you're going to see the shadow like you see at the bottom here, and you know that that lens is lifting off. Of course, and then this is what Dr. Morrison is going to talk about now. The other option to figure that out too is with sodium fluorescein.
Absolutely. Here's what it looks like when we have our patient with fluorescein. And what I'll do is I'll get my slit lamp ready, because if there's a lot of flow through, it just floods right in. And next thing you know, you have a lens that's moving around just full of fluorescein. But if you're quick, you can put a little bit of dye. I'll put a little bit, usually superior, maybe a little on the lid. You don't need much. You don't really want much. And then just have the patient blink and watch where it goes. And you can see in this patient, different patient, same problem. We're getting bleed through in the vertical meridian. Now, if you take a peek at the OCT next, you can see here on the vertical, a little harder to see in the inferior. So if your resolution is good enough, you can see edge lift. So that just proves the story. So we can find out where this patient's getting debris. And both of these patients had complaints of fogging. Now, is it true, you know, physiologic fog that's coming from the eye? Not necessarily. We don't know that yet because we haven't really created the right landing zone yet. And the first change we made in both these patients was the landing change. Now, here's the video. I'm so proud. Let's see if it plays. Let's see. So here it goes. So this is the Squeegee technique. So it's just a little out of order, but it gives you an idea. So we just made this video real quick the other day in the clinic to show you an example of how we squeegee. So we put that lens, usually put a little drop of fluid on top of the squeegee so it's not too dry. And you know, you really just place that squeegee on and squeegee it. Try not to remove the lens and pull the lens off, so you're just kind of going back and forth. And the most effective way to remove the squeegee, the shadow will block my fingers, but you pinch it off without pulling back. So you push against the lens a little and pinch that squeegee right off of there, leaving a nice fresh lens. And that's a technique that the patients can use during the day.
Yep, that one's really good. You can also do it kind of just like on a side. If your patient keeps pulling the lens out, then instead of sticking it straight on, just do it like a bit of an angle, and you'll get it so that it won't stick on. You're just using that almost like sharp edge of the inserter or remover.
Absolutely. Now, conjunctival cheilitis is something I see in probably, you know, more than 50% of our dry eye patients, and for a variety of reasons. Typically, some of these patients with a lot of inflammation or who have had, you know, Stevens-Johnson's or all these, you know, other inflammatory conditions tend to have a little bit looser conjunctival tissue on top of the sclera. And so our patients tend to be a little prone to what you see here, which is conj prolapse. And again, in a quadrant, you know, sometimes you can't avoid it. We all know that we put up with some conjunctival prolapse from the conjunctival cheilitis in some patients, but we try to minimize it. And the reason for that is because too much space and blocking that limbal area, we can end up creating an area that does not get oxygen in these patients. That can lead to neovascularization and other complications. So reduction of excessive limbal clearance and trying to achieve a more symmetrical clearance is very, very helpful. Now, fenestrations, I would argue, are the new black right now. I have really fallen back into a pattern of, I'm using them for so many different indications right now. And a big one is reduction of suction. Patients that are very sensitive, I'll use it a lot of the time now, just to help to relieve some of that pressure if they have a hard time with the dexterity of removing these lenses, and avoid constantly pulling on those tissues. And then of course, you know, the underlying theme, manage the dry eye whenever you can. Here's a case report. This is kind of a fun one. We wanted to kind of include a full scope. This is not this patient's eye, by the way, but what I wanted this picture to show, actually, if you flip back one more time, this is an eye that has a lot of comorbidities. So this happens to be a dry eye patient. This patient has had multi surgeries. Lots going on for this patient. And just remember that our dry eye patients often do present, as you mentioned, with a variety of different conditions, and looking at these people as a whole human, and you know, their eyeball, not just the dry eye portion, sometimes is necessary. This is a patient who was referred, 63-year-old male. He had a history of being referred to our clinic. I think you started with him in 2018 or maybe 2017. You probably don't even remember this patient. But he had traumatic glaucoma, corneal scarring, lens implant, fixed pupil, and a whole bunch of scarring, including kind of a resultant endothelial cell count that was quite low. I believe you actually started, and this might be a surprise, we didn't go through this case yet, so this is a memory lane for Andrea. and I'll tell you guys where we took it this year. Best vision with glasses very low, and ended up failing on his sclerals because of edema. And this was largely related to kind of a non-robust cornea, secondary to all of the surgeries. Now, the patient loved the scleral though. And he kept on asking me for it. He told me this, and it just wouldn't work for him. So he failed out of it, and then, you know, was referred back for another corneal surgery to try to improve the robustness of the eye. Let's flip forward here, and we have one pole EV. This will go real quick with this. So this is just an interesting. Andrea and I were wondering kind of what the rest of the world is doing. What is the lowest endothelial cell count that you would fit a scleral lens on? And we'll.
Yeah, I mean, a lot of practices don't have it.
Yeah.
So, you know, our practice doesn't. We co-manage with our ophthalmology team, and we say, hey, can you just send us over these endothelial cell counts on any transplant patient if possible? But honestly, any patient you send for a scleral, could you please just send it over? Sometimes we'll specifically ask for it too if they haven't had it. We'll like send them back and say, hey, can you go get it?
Yeah, absolutely. Yeah. So yeah, this is great. And the answer too is really, we just wanted to know what everyone else is doing out there. And the answer is there's no really black and white. Every patient varies. You could have a higher endothelial cell count to fail, a lower. Generally, we look at about 800 to 1,000 is kind of risky, but sometimes we attempt it. And it's just one of those things that, you know, you just need to really monitor those people really carefully.
Yeah, and put things in the lens right away, like fenestrations, put them in, you know, a really high oxygen permeable material, the highest you can possibly get, and maybe even channels, whatever you can do to increase oxygen if you're going to go fit them on a low endothelial cell count.
So that's, Andrea just finished the case, which is perfect because we can move forward. So here's the cell count. We'll go through these fairly quickly so we can get to the most kind of a new topic, which is mental health related to COVID-19. So low count on that right eye. Here's an example of cornea edema with lens wear. This is the patient with the fixed pupil beneath and a whole lot of edema. So our case discussion, basically after having another surgery, the patient returned, and we did add all of those features because we had them available to us now, and he'd had a surgery to make his cornea just a little bit more robust, but it was really, really hard. We put him in the highest DK material, decentered the optic to minimize those extra spaces where we may come into complications with the excessive clearance. We fenestrated the superior mid-periphery to address his superior edema with a channel through the middle to address his nasal edema. And so it was quite the case and really fun. So digitally created these lenses for him, just some imaging to show you. Here's an example. His microcyst or macrocyst in this case is imaged on the top, and this is another patient of Andrea's. These are kind of not the greatest. This is what we're trying to avoid. And so we couldn't let him wear a lens when he's getting this amount of fluid. Although those are old surgical sites, it's pretty hard to avoid. The new lens design after he'd had surgery was much better. So he ended up, we eliminated his edema, and I'll just show you here. So much better through the same spots. It wasn't persisting. He could wear the lens for 6 to 8 hours on those days he wanted to. 20/20/40 vision, able to hike, really happy because the main complaint was originally his dry eye symptoms when biking. He's very outdoorsy until the fog started. And so he was great. This is an image from the West Coast Trail that I just hiked about a month ago. Foggy beach, and before our eyes with this patient, the remedy was the viscous preserve-free tears, 2 drops in the lens reservoir, fill it up with the saline, and then his fogging went away. It cleared.
Oh, nice.
Beautiful. So scleral cleaning care, we just wanted to include a quick safety just so that you are aware that there are protocols, especially with COVID. The times that we're living in now, safety is extremely important. So when we're fitting, you know, any lens modality for any age and any reason, safety, I have to always mention that in every lecture, just because it's kind of the ship that could sink everybody if we end up with complications secondary to infections and safety. So follow your protocols, and then we'll all be able to fit these lenses for a long time. Now, here's one of our favorite topics, as kind of one of the most heart-wrenching topics, actually, in some cases, just because of the impact of mental health on our dry eye patients. So we'd like to hear from you. How often do you encounter mental health concerns with your dry eye patients?
And sometimes it's something that your patients, honestly, some days you think you're a therapist because they just come and they spill it all to you. And other times it's something you don't uncover until a little bit later too.
And, you know, we're right on the weekly, I would say, both of us. Yeah. It's really incredible what we're encountering.
Especially COVID, it's almost daily now.
Oh my gosh, for one reason or another. And I think that no one's alone in that. And it's really important to think about this because on its own, before COVID times, the impact of dry eye has been severe for some patients. It results sometimes in a loss of livelihood, inability to take care of your family members. Dry eye patients sometimes come in with a failure to have hope for their life. I had a very, very close friend who I had no idea was struggling so much earlier this year tell me that she was worried that she would not be able to be a good mom for her toddler. And that's horrible. And so, you know, on its own, dry eye has this huge impact, always has. And we've really seen in the clinics the intense and notable impact of COVID. Mm-hmm. And this is real for all of us. We're all facing this. You know, I find even patients are a little shorter with their, you know, patients for waiting for lenses even. They will take it out on your staff. And it's even more important for us to be on top of taking care of these patients, making sure things are going smoothly in the clinic as far as things like orders, everything that we're doing for them. People don't have much patience these days, mm-hmm. and remaining positive. So it's been a huge, huge impact for sure. We find that it goes a long way to work toward interdisciplinary care. And it comes up very frequently where we may have a patient that is already supported. So they're referred by their other providers for this as a last resort and already have had a psych evaluation, already have resources and things set up. We also get patients that are in the reverse, that are coming through the, you know, vision care provider chain and still really, you know, don't see their primary care doctor often. It's very obvious that they're way more upset by these lenses than what is healthy for them, or by their dry eye than what's healthy. And a lot of times, you know, I know Andrea and I are very passionate about this topic because we, you know, we really appreciate the community that we have. You know, with all of you, the Scleral lens, we're all right up in it. Patients sometimes feel very, very alone. And this is actually a book that my daughter has that I thought was very appropriate when it comes to opening up your heart and your doors to be able to involve other health professions to help these patients. Together is definitely better. A vision is like a dream. It will disappear unless we do something with it. All that matters is that we have to start treating and doing something. So wherever that is for you, whether you're just starting to fit, I look at this for lots of reasons, or a patient just starting to try to find answers to their problems, we just have to start somewhere and just stay calm. Can't do it alone. Don't pretend you can. Life is beautiful because of the people we meet and the people that we work with and all of you, and to go far, go together. And so that's really the message that we wanted to put out there for you when it comes to these patients with mental health issues and dry eye concerns and our advanced ocular surface disease cases. Co-management is really something that patients benefit from. When it comes to communicating with these people, here's a few pearls. First of all, listen, because they're going to come in with a unique story. They have maybe had, you know, hardships that are related to their dry eye, had past failures, as we mentioned before, with other prior fits before they reached one of the, you know, a practitioner that's had education like these types of CE events and had experiences to improve things for them. Acknowledge dry eye even in the absence of signs, and that's a huge thing for these patients. The ones that I know you've had quite a few recently, and I have too, where, you know, it's a teetering, it's a really tricky scale, and you certainly don't want to tip it for somebody because patients, they're not likely to make something up. If there's a patient in your chair that has a concern, there's a reason for that concern, and you go on that attitude and approach to support them until proven otherwise, or until they're in the hands of somebody else. And it's really important to acknowledge their symptoms, tell them they're not alone, make sure that you do let them know that there are resources and others that are in similar boats, but at the same time, I cannot understand everything you go through. You're the only one that walks your shoes. I can be here for you, but your journey is valid and it's something that only you can really experience. So we never try to take away from a patient experience just because we see these types of cases almost every day.
Yeah, and make sure you have some sort of guide in your office so that your staff know what to do when they've encountered these situations. So if you have a patient that has immediate plans, that is suicidal, your staff need to know what to do. If they have just ideation but no immediate plans, you need to know what to do then. Make sure you have all the numbers for any community supports if possible. It's going to be different in every place, so we recommend having a guide now before you run into these patients, maybe tomorrow.
Now, finally, in closing, just some of our take-home pearls again that we put together as a team. We're really, you know, obviously passionate about this area and have a clinic just full of patients that We find it very rewarding to help them, and I know a lot of you do too, and past, present, and future. So just remember a couple things. Sclerals, in some cases, we don't want to be jumping right on board right away without making sure that we're treating the symptoms. And dry eye, sclerals treat symptoms, they don't treat the cause. And so as a last defense, but not necessarily one to shy away from, because as you can see, there are a lot of indications for scleral lenses. So patients that fit the part for multiple indications, get them into it, but don't overpromise that, you know, the device before, by getting ahead of yourself. Usually bigger is a little better. Protect that ocular surface as much as possible in these patients. Definitely consider trying new materials, new solutions. You know, try coatings that are available, and every patient's a little bit different. As I said before, everybody has their own unique fingerprint in terms of their ocular shape, also their tear chemistry, also their daily habits and what they're exposing their eyes to. One solution does not work for everybody. Make sure that the lenses that fog are aligned, and make sure to, you know, kind of try things like increasing viscosity, trying nutrition factors in that lens reservoir as well at times to help the corneas that are really, really sick to heal. And then, you know, finally, don't forget about the amniotic membranes for exposure. Those exist as well and can be very helpful as an additional tool. So scleral lenses can and do change lives for the better in a multitude of indications, including ocular surface disease. So we wanted to thank you so kindly for spending this time with us. There are a few closing slides that we have references here, lots of references, and I think we will pass it over first to, I believe, to Elise to just finish up here. Dr. Kramer, do you have anything else you want to say about the next presentation? And then we do have one final poll for questions. If you wanted, anyone wants to stay, we'll stay as long as there are questions.
Perfect. I'm just waiting for those questions to come in. That was amazing. Very, very amazing presentation, and I learned a lot. So thank you very much. So again, I'm just waiting for those questions to come in.
And you know, if you are still online with us, if you see the poll question, and oh, thank you very much. We really appreciate that positive support. Thank you.
We wish we could see you all.
Yeah, hopefully in person soon. We miss you. We miss all of you. Okay, perfect. Okay, so you know, I just talked. Why don't you, if you do want to start with that one?
Yeah, I can start with autologous serum for sure. So you can use 50% or 20%. I usually use 20%, and what I do is I tell them to put 1 to 2 drops of the serum in, and then just fill it up with their preservative-free saline. I don't have them replace, you know, unless they're fogging, then I have them replace it. I find that sometimes if they put in and take out the lens too much, they're actually kind of disrupting the goblet cells, and they can make themselves produce more mucus. So for these dry eye patients, I actually have them leave it as long as they're not running into any problems. They can do, we recommend preservative-free artificial tears over the top of the lens if, you know, they're just feeling dry on the outside. But as far as the inside goes, once it's there, if they're not having any problems, leave it. Hopefully that answers the question. Do we find PRP eye drops work better than serum drops? Yes and no. I've had some patients say yes, it makes a difference, and I've had some say they didn't notice anything. So generally, I try PRP drops after I've tried autologous serum drops. I don't know about you, Dr. Morrison, if you try them in differently, but generally, like, you know, if autologous serum makes no difference, I go to PRP.
Yeah. Okay, so prefer fenestrated. So I love that question. To be honest, I do. Yeah, I'm starting to really move into it, and I'm finding it's helping a lot. The fenestrations help a lot. Yeah. Viscous solution, probably Celluvisc is my go-to. How about you?
I like Celluvisc as well. I have a whole bunch of patients that use, honestly, a weird cocktail. Like they'll put Therapies tears in there. They'll put like all sorts of weird things. But, you know, in our practice, I do like Celluvisc the most. Here in Canada too, we have one called Eye Drop, a company called Eye Drop, and the gel. Sometimes I'll have patients use that instead. It's just a multi-dose preservative-free, really thick tear. And sometimes here in Canada, they can use that too.
Yeah, as long as it's preserve-free and it has viscosity that adjusts the fluid force beneath the lens. So I think there was a question about the lens material.
Yes.
So Andrea, usually lens material anywhere around 100 to start. Sometimes if you don't have any concerns about edema, lenses that have just a slightly lower decay but within reason will actually wet better. And so you try to get the lowest decay that you can get away with a safe vessel that can be worn for many, many years. And then if you
before I guess before the advent of some of the more option, I guess Hydropeg, I would actually go with Tyro 97. I used to use that a lot, but now I don't because Hydropeg exists. So now I usually go, when I have a patient, I will usually start with like Boston XO or something like that. But for a lot of these patients, I now can go to Boston XO2, put HydroPig in there, Optimum Extra, Optimum Infinite I've used as well. I've also used Acuity 200. So if you're looking for that really high oxygen, there's a lot of options now that there's HydroPig, because I could never have used those high oxygen options in the past.
Probably better to squeegee first if you can, if you're certain that it's the front surface. Obviously, the squeegee will not remediate any of the post lens reservoir fog, but the anterior surface, definitely squeegee it. It's kind of like a soft lens. Do that, you know, the Nike sweep before you pull the lens off if you feel like you have a fuzz on it. Slide it over first, let it sit. Same with the scleral. If you can squeegee and avoid having to go on off, it reduces that inflammation that Andrea is talking about that can really build up when a patient is constantly aggravating the eye by taking the lens on and off.
For your post-graft patient with a scleral, what material should you use? Again, I always start with Hyper DK, Boston XO2, Optimum Extreme, Optimum Infinite, anything like over like 120 usually is what I start with. And then I just monitor it. And we didn't really go over this, but we take pachymetry before we start any fit. So we know baselines. And then we take pachymetry directly after you have put the lens on, so that if the cornea is swelling, immediately you know, because the thickness is going up. So I'll monitor that first, then I'll add fenestrations. But if we already know we're dealing with a really low endothelial cell count, I imagine you just put them in there.
Yeah, I've been really, just the patient population that we tend to get, I'm using fenestrations a lot for a lot of reasons. 2 reasons. One is oxygen, so any eye that I perceive to be high risk, and I want to even just really avoid complications. And then a lot of patients with dexterity or issues with, you know, suction, deep eyes, I also like the fenestrations to help with the reduction of suction on removal.
Yeah, how often do you follow up with your patients?
It depends on what point. So basically, for any patient that I would have like a graft, for sure every 3 months in the first year, and then I follow every 6 months. What about you?
Yeah, every 6 months for sure. But if I'm worried about somebody, it could
Every
be
month,
any
yeah.
month to 3 months.
Yeah, that's right. Just depends on how they respond. And definitely when you're in the middle of the fit, you need to rule out edema and complications in that first 3 months to make sure that you're not going to end up with a patient that's getting subclinical kind of mild edema that can cause, you know, failures and problems down the road.
I think, Elise, you were trying to say something?
Yeah, I'm trying to get, sorry. I was just thinking how interesting it is that you guys use fenestrations, and I find that a lot of people in other countries use them a lot, and it's not widespread yet here in the US, but it's really interesting, and I look forward to that kind of developing over here as well.
We should have a meeting over wine, Elise, and have a fenestration meeting and put some info out there. It's kind of fun, hey?
Let's plan it. I do have an interesting question about autologous serum tears. So what are your installation instructions when putting that inside the bowl of the lens? Do they need to replace the fluid in the middle of the day, or do they just keep it all day?
I think we did that one, but yes, we usually, as long as the patient's having no problems at the beginning of the day, and then leave it. But if they are having fogging or they just feel like they're symptomatic, then certainly they can replace it throughout the day if they want. But generally, I just kind of leave if it's in there and there's no problems, what's not broken, we don't fix it.
Okay. And do you guys have access to Avisor solutions in Canada? That was another question.
Do you have access for what solution? Sorry.
Avisor, AVISOR. Do you guys have access to those?
Not to my knowledge.
No, I haven't heard of that one here in Canada.
Okay.
Okay, recommendations on cleaning solutions. Yes, it definitely changes per patient's ocular condition, but typically I would say most common would be a peroxide-based solution. How about you, Andrea?
Yeah, I like that one. Because I do so much HydroPig, I also do Boston Simplest too.
Yep, for sure.
Sometimes I'll do it depending on the patient because of what I trust them how to clean their lenses. So sometimes it goes from that, or like honestly, if I have these patients with really, really big fingers and they're these like the huge guys, and I'm like, ooh, I don't want you rubbing too hard. Yeah. So sometimes I'll change based on that too. But usually it's in Canada, at least it's one of those two. Obviously, there's so many more options in the States. They're so lucky. I miss, after we finished doing our residencies, we miss a lot of the solutions down there. But there's a whole bunch of new ones coming out too, I believe, from some of these companies like Tangible. So I'm really excited. We can't get any of the solutions from Tangible in Canada, but we're looking forward to it to see how well it works with their coating. One of the questions that we missed was, do you have any tips for persistent redness in the surrounding conjunctiva? Honestly, that's a hard one because you get these big lenses and they look amazing under the lens, and then like just right at the corner where it's exposed, they're still getting that redness. sometimes it can be that they actually need conjunctival cheilitis surgery. So look for that too, because sometimes like they're actually getting that wrinkling of the conjunctiva. And if you actually have a physician resect that can actually improve the redness a little bit as well. So I've done that. And the other thing too, like if you've done absolutely everything for this patient, you're still getting redness and there's nearly nothing else that you can do, you have always got Lumify. So that's an awesome one. And if you're in Canada and you can't get Lumify yet, we compound 0.025% bromonidine as well. So we will get that for patients, so it's much more expensive. So if possible, you know, if you can go to the States next time you're down there, Canadians, and steal some back for your patients, they'll appreciate it.
I do find reducing suction as well on a daily basis will reduce rebound redness, and then optimizing landing. So sometimes freeform can improve depending on the patient's eye. Good results with iPrint Pro, always, for sure. iPrint Pro still cost is high. There is another option, I believe, that's available everywhere. We have it. That's iFit and iScan. So it's just a little different, and it's honestly worth the, you know, it just comes down to that's a whole practice management lecture, but cost is not an issue in our practice.
Yeah, we'd love to do that one. But yes, iFit Pro will work for a variety of patients as long as they don't have massive conjunctival irregularities. So, you know, if they have like shunts or blebs or something, absolutely this won't work for them. But if they're just a normal-ish eye, iFit Pro, your patients could get it for probably a third of the price of what iPrint Pro, the original, is. It just has less data points that they put into it, but it'd be a good idea to reach out to those guys. And if that's something you're interested, ask them a little bit more about that.
And there are other vendors and other manufacturers now. And actually a lot of our, you know, typical, you know, names of lenses, almost, I would say half of our manufacturers are moving towards some version of a freeform based sort of influence, whether it's full freeform or it's, you know, a data-driven design system. And it is just such an exciting time for lens design right now because of that. I get really excited about it because it's just so great in the clinic and so great for patients.
Yeah. So did the fenestrations compromise the hydropeg coating in your experience, or the ability to even do hydropeg?
Yeah, so no, they can hydropeg them, and I have no idea, to be honest, if there's any compromise. I've really only been fenestrating really heavy for about 1.5 years now, and it's a work in progress. So that's an interesting thing that we'll probably need some kind of study on. So anyone out there that has an idea of things that we can look at, let's do it.
Yeah. Do you get more fogging with fenestrations? That's another one. Lots of fenestration.
Depends on the fenestration. So you can get more fogging if they're not fenestrated the way that they should be. So like fenestrations are tricky because getting them in the right, and I'm still learning and figuring out, and it's different on every patient because it's really not just a standard distance on each lens. It's relative to the landing and the limbus and the clearance over what part of the cornea. And then the other thing that's really important, I find, to avoid fogging and air bubbles is the size of the fenestration. So again, some tear film is really thick and gunky with stuff and it clogs it right up. You're not going to get any oxygen through that thing in a really tiny fenestration for that patient. So it really depends. I usually fenestrate. I like to fenestrate usually around I guess it would be 10 and 2 o'clock-ish. And depending on the shape of the eye and where the lens sits, that's where the lenses are fenestrated. And our manufacturers were all, you know, a whole variety of us are playing around with this a lot lately, and it's been a lot of fun. And I certainly have seen a lot of benefit to patients. Definitely, like I said, the two big things that really bug me is lens suction on patients that, you know, with these better, I guess more, I don't want to say glove fit because we never want to fit like a glove. We want tear exchange, but with those, you know, more optimally aligned fits, there are patients that do struggle. I personally feel I can always get that lens off that patient. Then you send them home with it and they, you know, end up with suction. And so that's a really big indication that our practice gets so many high risk eyes that having any tools that we can to decrease edema and increase oxygen to make it so these people can wear their lenses for their dry eye and their other comorbidities. So I just love them.
Yeah, and one really interesting thing, which we didn't really get into in the lecture, I wish we had 2 hours, but we only had an hour, is that with the fenestrations too, Dr. Morrison, when she had that patient that had that macrocyst at the very top of the cornea where there's a lot of scarring, you'll get this in like trauma patients. Like if your patient has a laceration injury or perforation injury, those are the ones I see with those macrocysts so much in those post-traumatic cases. And sometimes we'll put the fenestration right there, like right on top of that. So it might be like a little bit in from the limbus, but we'll put it right there. And sometimes it just gets oxygen right to that spot, and that's helpful.
Yeah.
Awesome. Let's just see. Oh, there's so many questions.
So much fun.
This is awesome.
So we're so grateful that you're here putting your energy into this lecture and spending time with us.
Not an advisor. It is in Spain. It's in Saudi Arabia. It's all around the world.
Yeah. So can someone? We would love if, and you know, anyone out there that's listening that has a heart for Canada, whoever is in charge of getting these things across the border, help us, because we try and it doesn't work. So any, Canadians do have a huge need, as with other countries, I'm sure. But yeah, we would love to test out these solutions. If there's anybody that has interest in discussing that further or has ideas, let us know. There is a couple distributors in Canada now that we'll be bringing in, like Precision out on the West has some options coming out, which is really exciting for us.
If you, I will look this up to figure out if it is the same as Boston, because I don't know. But if you want to email me, you can just email me at andrea.lasby@gmail.com. I'll look it up for you and I'll figure it out and get back to you. So just email me and I'm happy to figure it out and see. Do we do your own fenestrations? We don't. I wish we did.
I know.
Did you ever use it in your residency?
Yeah, so the schools all have have equipment to do that, and I think it would be something that, just know though, then you're in charge of that lens. And so for me, I think the manufacturers have it down to a science now. They're getting there, and I also really appreciate the, there's a lot of knowledge from many lenses made coming from our lens designers and manufacturers that can be really helpful. So yeah, we don't do it ourselves. I think the warranty for us, there's a couple manufacturers that won't fenestrate still just for that reason. And I prefer to have the manufacturer do it. I'm not interested quite yet in fenestrating.
Yeah, there's other things you could do, like channels and microvolts and other weird things to kind of promote more.
That's a very good point,
changes.
Because I know I obviously we have had a lot of interest in people asking us before this lecture, and anytime we lecture about this, about fenestrations, and I've been playing around with them a lot and having a lot of benefit. They also, the channels, microvolts, even notches on some patients, all these cool things we can do absolutely will be essentially, working toward the same thing, which is the most healthy medical device that we could create for these people.
Yeah, it'll be really interesting to kind of see how things change kind of in the future.
What the trends are going to be.
Yeah, so if you're interested in fenestrations, ask your manufacturer about it and see if they do it, because like Dr. Morrison said, some don't, but they might have other solutions for you. So certainly chat with them, because the manufacturers are the ones that know their lenses best. So if you ever run into a wall with these patients, you're like, I don't know what to do, I don't know how to change this. Take pictures if you can. Even your iPhone, like through the Ocular is okay. Send something to the manufacturer, tell them what's going on, and they'll be able to tell you, like, is there something that they can do with this lens? Or sometimes, honestly, you got to throw in the towel on a certain design and change and go to a different manufacturer. 100%. Doesn't happen that often to us anymore, but certainly it can. And, we go that way a lot.
Absolutely.
So I think that's it. Elise, do you have, oh wait, there's more. Oh my gosh. Is there any in the chat that you saw, Elise?
Tons, and a lot about fenestrations, and I have so many questions myself.
This is fun. We're fine to chat as long as people feel like chatting, whatever.
We're losing attendees slowly but surely, so I think we'll head out, but definitely to be continued. I would think we need a webinar just about fenestrations now.
I think we need what we should try for? Let's do a roundtable at GSLS or something like that.
Let's do it.
That would be, let's do an SLS roundtable at GSLS and get a group together and open it, whatever. Let's make that happen. That would be a lot of fun.
So if you can just go to the next slide so we can see for the next webinar coming up. This one's coming up next month, so don't miss it. We have Roxana Hamadi and Ashley Tucker talking about scleral lens hurdles, so that should be great.